Hello, I'm Dr. Mohamad Bydon. I'm a neurosurgeon at Mayo Clinic in Rochester, Minnesota. I'm a professor of neurosurgery, orthopedic surgery, and health services research. I want to thank the organizers of the session today and the Computational Neuroscience Outcome Center at Harvard for inviting me to speak to you today. Today we'll be talking about machine learning and predictive modeling. I have nothing to disclose. Machine learning is the process of computers making successful predictions using past experiences. And this can be used to evaluate patients' clinical and surgical outcomes using predictive modeling. This can be subclassified, as many of you in the audience well know, into supervised or unsupervised learning, with supervised learning where we're predicting a known output, unsupervised learning where we're searching for naturally occurring patterns within data learning. There's traditional statistics and there's machine learning. So in traditional predictive modeling, you're restricted by rigid assumptions that may not be applicable to the real world. And this requires a reduction in sampling and variables before you can run your model. Machine learning has no such assumptions, and it requires, in fact, abundant data prior to the learning algorithm. Supervised learning focuses on the classification of new data instance and prediction of unknown outputs. It requires a training period where a computer recognizes the input and the results. The algorithm is then tested to ensure correct predictions and to make it useful for making predictions with no known output. Unsupervised learning focuses on predicting patterns in data rather than output. This is used to identify mechanisms of a common unexplained outcome among the population. Machine learning and neurosurgery, the topics range from epilepsy and brain tumors to spinal diseases and AVMs. These areas focus on predicting survival and surgical outcomes. A common method of machine learning used in neurosurgery is artificial neural networks. Artificial neural networks is data of input and output is given through an artificial neural network and modified through training sets to successfully predict an output of from new data. And so input layers are put through hidden layers and then result in output layers to help successfully predict the new data that is fed into the system. Azimi et al. Used artificial neural networks to predict recurrent lumbar disc herniation. Artificial neural networks use baseline data and outcome, in this case, non-recurrent or recurrent lumbar disc herniation, to learn about the relationship between them. The model was trained and then used to predict results from a new set of baseline data. And in this case, they found that they're using artificial neural networks. They were able to create a model that predicted recurrent lumbar disc herniation with 94.1% accuracy. You can see several other examples of artificial neural networks in neurosurgery, and they're used in epilepsy, and hydrocephalus, and aneurysmal subarachnoid hemorrhage, as well as in new cerebral metastases after radiosurgery. Machine learning is important in neurosurgery because we can find previously unknown relationships between input and output. And so that comes down to preoperative, intraoperative, postoperative features of outcomes. This can be coupled with a neurosurgeon's clinical experience, whereby machine learning can aid in decision-making. And this can result in tailoring an individualized treatment for a patient. This is an example of a project that I was fortunate to be involved in, looking at predictive models and nomograms for predicting return to work at 3 months after cervical spine surgery. This was an analysis from the Quality Outcomes Database, which is a national registry data compilation from several hundred centers throughout the United States, several hundred hospitals from throughout the United States, looking at cervical and lumbar spine disease. So in this case, you can see the nomogram for predicting return to work after 3 months using machine learning with an area under the curve of 0.87. And so you can see the points along the nomogram. So you can see the variables that were important: age at surgery, were you a full-time worker or a part-time worker? If you were a full-time worker, you gained more points, meaning more probability of going back to work. Your education level: high school, less than high school, 2-year college, 4-year college, post-college. And again, the higher your level of education, the more likely you were to return to work. Employment, meaning employed but not working, or employed and currently working. Occupation intensity: is it a heavy intensity, medium intensity, light intensity, sedentary? Workers' compensation: if this was a workers' compensation claim, you were much less likely to go back to work. Your baseline NDI score: that's a patient-reported outcome measure. The Neck Disability Index. Your symptom duration: less than 12 months, more than 12 months, or less than 3 months, I apologize. Your predominant symptoms: was it myelopathy or radiculopathy? Levels fused: was it 1 level fused, 2 levels fused, or 3 to 5 levels fused? 3 to 5 levels, you're much less likely to return to work. And then your total points, your linear predictor, and your probability of going back to work. So you can see in the clinical setting how useful a tool like this would be to a clinician, an occupational health office, an employer, a patient themselves, as they look at themselves and their probability of going back to gainful work after surgery. Our group also worked to define the minimum clinically important difference for grade 1 spondylolisthesis, and that's also known as MCID. This was also using the quality outcomes database. So there was a development of a predictive score for discharge disposition after lumbar fusion using the quality outcomes database. This was another area that we thought was a good use of machine learning and predictive modeling. Predicting the best outcomes following minimally invasive surgery for grade 1 spondylolisthesis. Developing and validating cervical prediction models for patient-reported outcomes at 1 year after cervical spine surgery for myeloradiculopathy. And then other uses of machine learning and predictive modeling that my research group has been involved in this case, looking at the National Surgical Quality Improvement Program, also known as NSQIP from the American College of Surgeons, looking at the surgical risk calculator in elective spine surgery. And in this case, we looked at the calculator for patients undergoing a single level posterior lumbar fusion, and found, in fact, that the NSQIP calculator did not perform very well in predicting most outcomes. This was a calculator that was described with great fanfare and revealed with great fanfare that a significant amount of money was put into its release, and using machine learning and predictive modeling and assessing the outcomes of this calculator, we found that in fact the release calculator was not very predictive of outcomes. We also looked at whether machine learning algorithms could accurately predict discharge to home versus non-home, meaning home versus rehab or skilled nursing, as well as early unplanned readmissions following spinal fusion. We looked at a total of 60,000 cases almost in this case, and found discharge to non-home for 12.6% of the patients, unplanned readmission for 4.5% of the patients. And we were able to show with good discrimination, an area under the curve of greater than 80%, algorithms that demonstrated the ability to predict non-home discharge, in addition to algorithms for unplanned readmission, although those were poorer in their predictive performance, meaning likely the data that we put in was not enough in order to adequately predict that particular outcome. We looked at prognostic factors associated with best outcomes following fusion for lumbar degenerative conditions. This is a group led by Steve Glassman and colleagues. And in this case, we looked at the utility of the frailty index for predicting adverse outcomes following an elective anterior cervical discectomy infusion, also known as an ACDF. This was done by my group, and what we found is that compared to age, BMI, ASA classification, and then we looked at predicting minor complications, major complications, and any complication. And what we found, in fact, is that the 5-item modified frailty index does not perform as well as age and ASA score at predicting complications. This also I found to be interesting because a lot of effort has gone into creating the frailty index, and a lot of attention has been paid to that. And the fact that it was not as predictive or as predictive as age and ASA score, which are readily available. They don't have any items to them. They're not very difficult to calculate. What's the age? Every patient going to surgery has an ASA score because anesthesia records it on every time. And so that we thought was interesting, an interesting result from this look. Thank you very much.